So today we'll be seeing that how to treat hypoxemia. It's a very interesting topic. That is how to treat hypoxemia or hypoxia. So we know that any patient should have saturation of at least 99 to 100% on room air. So anytime if someone has saturation lower than this, it can be 88, 86, 89, 67. We need to basically find out the cause behind it and we must treat it. So it's very simple. ABG, that is gas analysis can tell us what exactly is the PO2, and PO2 can definitely tell us about saturation. So chest X-ray gives us an excellent clue regarding the hypoxemia. So chest X-ray, it can show consolidation or a patch or a pneumonia. Consolidation means pneumonia in short. So it can be viral, it can be bacterial, or it can be fungal. Most of the time, it is either viral or bacterial. It's very simple to understand. Most of the time, if it is viral, the patient should have a consolidation patch in bilateral lung fields. Whereas in bacterial pneumonia, it is almost always unilateral to start with. It may uh, have a bilateral presentation, but most of the time it is almost always unilateral. So in this, we can see very well it is a very good or very well localized unilateral patch. So mostly this is a bacterial pneumonia. We know this patch is there means the all the alveoli which are there, which actually is the basic unit for oxygenation, is involved. So we have hypoxemia or hypoxia. So bacterial pneumonia is one of the most important cause. So it can be treated with antibiotics, and as soon as we start the appropriate antibiotics, the symptoms which are associated with pneumonia, like fever, chills, weakness, cough, lethargy, all these symptoms should improve. So automatically the hypoxemia should also improve. Same way, if it is viral pneumonia, same way the patient will definitely show a patch and symptoms associated with it, like the cough, lethargy, shortness of breath, reduced appetite. All these symptoms should also improve. So, and most of the time, oseltamivir is used in any patient who is suspected to have viral pneumonia, especially if the patient is more than 50 years of age, who has diabetes, hypertension, ischemic heart disease, or CKD, or cancers. So if the patient is taking some immunosuppressant medicines like methotrexate or sulfasalazine or any other immunosuppressant medicine, then antiviral medicine must be started. So, pneumonia or it is an infective pathology. In pneumonia, we can see the patch, we can have wheeze, rhonchi, or creps, but they are very non-specific. So, one of the most important thing is this uh, pneumonia, which we saw is viral and bacterial. Second thing, patient may have lower respiratory tract infection. So, patient may not show any patch or patient may not show any patches in bilateral lung fields, but we may still auscultate fine creps which can be there in uh, lower lung fields or middle lung fields or upper lung fields. So they may be distributed unequally without any obvious lung pathology or a patch on the x-ray. So that time we can label it as that patient has LRTI. So patient may have lung related symptoms like cough, shortness of breath, reduced appetite, fever, lethargy. These all symptoms with these creps can definitely tell us that the patient has a lower respiratory tract infection without a particular pneumonia patch. So that tells us about the LRTI or lower respiratory tract infection. Other things which can definitely tell about is hypoxemia very commonly can be because of the heart issue. So the patient may have acute left ventricular failure. So if the patient has left ventricular failure, definitely we know that heart pumps blood to lungs, in lungs, it gets purified or get oxygenated and again goes to the heart. So if patient has left ventricular failure or left-sided failure, it can be mitral stenosis, mitral regurgitation, aortic stenosis, aortic regurgitation. It can be myocardial infarction or any left-sided pathology. So left ventricular will fail. So it will cause pressure on the left atrium, and in left atrium we get the blood flow from the lungs, which is pulmonary venules, all they drain into the left atrium. So because of the increased pressure in the left ventricle, automatically there will be increased pressure in the left atrium. It will then put pressure on the pulmonary venules, then the pulmonary capillaries. So because of the increased pressure in the pulmonary capillaries, there will be leaking of all this fluid into the interstitium, and that will cause basically hypoxemia. So very commonly, this is a very typical representation of pulmonary edema. That is what we call it as pulmonary edema. So if pulmonary edema is there, we need to simply see whether this patient has some cardiac pathology, which can be ascertained by ECG, 2D echo, even chest X-ray can also help. And most of the time this patient has hypertension, diabetes, or any other pathology like CKD. So we need to take care of the sugars also, blood pressure also. ECG can tell us about the ST elevation MI or non-ST elevation MI or unstable angina. So it should be treated as per the guidelines. And most of the time, if it is left ventricular failure, we very commonly see the fine crepes, which will be seen in bilateral lower lung fields, is very commonly seen. Patient may have bilateral pleural effusion or unilateral pleural effusion can also be there, or crepes may not be there in earlier stage, but most of the time they respond excellently to the diuretics and BP control and oxygen therapy. So this is the cardiac cause. So we know that hypoxemia very commonly is because of the lungs. So in lungs, what we'll see is whether the patient has pneumonia, which can be viral, bacterial, which should be treated accordingly. Patient may have lower respiratory tract infection. In lungs, uncommon causes like pneumothorax can also be the possibility. So if the patient has pneumothorax, then X-ray will clear-cut show pneumothorax if it is causing hypoxemia, and such pneumothorax may also show the shifting of the left ventricle or right ventricle or right atrium or mediastinal shifting. Such patient must get the intercostal drainage as fast as possible. Then only that type of hypoxemia will improve. In heart, as I told you, left ventricular failure, which can be stable or chronic, which can be caused by the MS, mitral regurgitation, mitral stenosis, aortic stenosis, aortic regurgitation, chronic hypertension, or accelerated hypertension, or hypertensive emergency, or urgency, or myocardial infarction, or ventricular septal rupture, or aortic atrial septal defect or ventricular septal defect, which puts more pressure on the left ventricle or left atrium. That automatically puts more pressure into the pulmonary capillary system, and that will lead to the pulmonary edema, that will lead to the uh, hypoxemia. So these are the very common causes. The other uncommon causes is like bronchospasm. So in bronchospasm, actually the patient may not have any infection. Patient may simply have COPD or asthma, where there is increased bronchial sensitivity. So where the bronchi, which are actually pretty wide apart, which are not constricted, they get constricted or they become more hypersensitive. That can be to the air, to the cold, to allergen, or to infection or to any inflammatory markers also. So if the patient has sepsis, infection, left ventricular failure, or lower respiratory tract infection or allergy, there will be exaggerated bronchial reactivity. So there will be bronchoconstriction, and because of the bronchial constriction, airway air will not flow into the lungs as much as needed up to the alveoli, and that can also cause hypoxemia. So it can be treated with bronchodilator. So underlying cause has to be treated, like if it is allergy, hydrocortisone, methylprednisolone has to be given. The allergen has to be removed. If it is left ventricular failure related mm, bronchospasm, then left ventricular failure has to be treated. Appropriate drugs like injection nitroglycerine, or if it is MI, dual antiplatelets, Glixane, or heparin has to be given and it has to be treated. And if it is plain asthma or if it is simply an exacerbation of COPD, then bronchodilators like short-acting bronchodilators like salbutamol, ipratropium can be used. Uh, if it is persistent, then long-acting bronchodilators like tiotropium, salmeterol can be used. And definitely steroids are the most important drugs. Very commonly post-operative also, a patient may have hypoxemia. So in that case, most of the time post-surgical patients remain pretty well. So they may not have any symptom and their hypoxemia is always mild. So saturation may range from 90 to 95%, and they very typically have bilateral lower lung field creps. So that is what is we call it as post surgical or post operative hypoxemia. That is because of the atelectasis of the lower lung field alveoli. That is very easily treatable as soon as the patients start doing in situ spirometry or their anesthesia wears off. The saturation also should improve over a period of time. Patient may have significant low HB hemoglobin because saturation is basically oxygen pressure, which is actually linked with the hemoglobin. So if there is low hemoglobin, patient can definitely have low PO2 because this saturation means oxygen. This oxygen is actually bound to hemoglobin. So heme has to be there. So heme is not there means HP is not there means if there is significant low RBC count, if the patient has significant anemia, then definitely patient saturation can be definitely lower. So in that case, we can transfuse PCV, um, red blood cells, and the saturation can definitely improve. Or we can give injection iron, injection B12, or folic acid and other vitamin Bs to increase the hemoglobin levels, and eventually the saturation should improve. Very commonly, acute hemolysis can also cause the low saturation level. So acute hemolysis can be easily found by low hemoglobin levels, increase reticulocyte count, increase lactates, increase lactate dehydrogenase levels, increase total bilirubin. Most of the time, hemolysis bilirubin usually increases, but usually doesn't go beyond 4 milligram per cent. So it usually doesn't go beyond 4, and most of the time it is always the indirect hyperbilirubinemia if it is hemolytic anemia. So increase reticulocytes count, increase lactate, increase LDH. These are very peculiar findings which tells us about acute hemolysis, and it can be because of the drugs, it can be because of the poisoning, it can be because of the toxicity, it can be because of the trauma. So this hemolysis has to be seen. What is the cause behind this type of hemolysis? So for the other thing is severe sepsis, persistent fever, high levels of inflammation that can be because of anything, also increases significant pressure or immunity. So if the patient has severe sepsis, or if the patient has persistent fever spikes, or if the patient has inflammation because of the toxicity, because of the poisoning, because of the trauma, because of the surgery, because of the huge bleeding anywhere in the body, at that point, because of the inflammation, our body remains at a significantly higher level of usage of the oxygen, usage of the hemoglobin. At the same time, if the patient has severe sepsis, bacteria also, which are there in significant amount, use oxygen at a huge level. So our immunity cells like uh, neutrophils, lymphocytes, eosinophils, liver, kidney, heart, they always use a very high level of oxygen. They consume lot of oxygen. That is the reason why patient may definitely have hypoxemia. At that particular instance, like sepsis, MODS, severe inflammation, CRP can be high, IL-6 can be high. These inflammatory markers can definitely be seen, which will be in a very high levels. Also, a patient may very commonly shows tachycardia, tachypnea, and a patient very commonly may also show signs of MODS, like there will be increased creatinine, increased urea, there will be increased SGOT, SGPT, there will be increased bilirubin levels, there will be significant marked signs like reduced appetite, lethargy, nausea, vomiting. All these signs can be definitely high. So these were almost very much different causes of hypoxemia and the way they should be treated. So for today, this is all, and we'll come up again with some interesting topics. And thank you so much.